Hello, my name is Wayne Kubal from the University of Arizona, and for the next 20 minutes, we'll be discussing brain tumor emergencies. I have a single financial disclosure, and I'd also like to thank the organizers of this course for inviting me to participate in RSNA 2020. It's always been a great honor for me to participate in this meeting. Brain tumors and their mimics are frequently encountered in the emergency setting. Their presenting symptoms are often nonspecific. In fact, many are detected incidentally. We'll utilize a case-based approach during this presentation, emphasizing common pathologies that you will likely see in your very own practice. Case 1 is a 56-year-old who fell from a roof. We obtained a non-contrast CT, and you can see the left-sided scalp hematoma, but I'm sure you're also noticing the hyperdense mass. Now, I find the coronal and sagittal reformatted images quite useful, and in this case, not only do they show the hyperdense mass, but they show that it's dural-based, extraaxial, and lies near the superior sagittal sinus. At this point, I'm thinking meningioma. We obtained an MR, and I'm showing you two contrast-enhanced images. You can see that the lesion shows uniform enhancement. It lies near, but does not invade or narrow the superior sagittal sinus. This is an important piece of information because if surgery is contemplated, the surgeon needs to be very careful not to occlude the sagittal sinus. Surgery went well, and at pathology, the lesion turned out to be, as expected, a meningioma. Here's a related case. This is an 82-year-old who came to our emergency room following a motor vehicle collision. The non-contrast CT shows a calcified dural-based mass in the left cerebellopontine angle cistern. I saw no evidence for traumatic brain injury, and this looks like a calcified meningioma. Here are the bone windows, just so you can see how very densely calcified this lesion is. And although the lesion was not removed, it certainly looks like a meningioma. Another related case. It's a 32-year-old who presented with progressive upper extremity numbness. The non-contrast CT is a little bit challenging, but if you focus, I think you can see that there's a mass in the posterior fossa at the level of the foramen magnum. It lies just to the right of midline and has some considerable mass effect on surrounding structures. And it's hard to see because it's only very slightly denser than the normal brain. It's certainly a lot easier to see on these post-contrast MR sequences. It looks like it's dural-based. It's certainly showing uniform contrast enhancement. And once again, I thought this lesion was going to be a meningioma. But I got a surprise when the pathology came back. It turned out to be a solitary fibrous tumor. So it just goes to show that imaging is good, but virtual biopsy is still a ways off, at least when we're talking about intracranial lesions. Here's a different sort of a case. It's a 70-year-old who presented as a stroke alert. So we narrowed our windows, looked pretty carefully, and were able to find a right frontal area of decreased cortical density. Could this be an infarct? Well, sure it could, particularly given this clinical scenario. We proceeded with a stroke workup, and I'm showing you two images from our CT perfusion. The cerebral blood flow and cerebral blood volume maps are symmetric in the frontal lobes, not what one would expect in an acute or subacute infarct. We moved on to MR. The diffusion is negative, again showing that this is not an infarct. The flare and T2 are positive. They show a good-sized lesion, but notice that that lesion has very, very little mass effect for its size, and that means that we're dealing with an infiltrative lesion. Here are the pre- and post-contrast images, and you can see that there's no contrast enhancement. So putting together the findings of an infiltrative lesion, no surrounding vasogenic edema, and low density on CT, it's consistent with a low-grade glioma. And at pathology, this turned out to be an astrocytoma grade 1. Here's a related case, a 42-year-old with altered mental status. And we quickly realized that this patient had a left frontal area of decreased density, but there was also some mass effect. So we weren't thinking so much about an infarct in this patient. We went to the MR. The diffusion is negative. On flare, you can see that there's T2 prolongation. And on the post-contrast T1, you can see that there is no contrast enhancement. These findings, again, are consistent with a low-grade glioma, and at pathology, this lesion turned out to be an oligodendroglioma. I think it'd be very difficult to differentiate this lesion from a low-grade astrocytoma. Here's a different sort of case. This is a 78-year-old with memory loss. And we see a low-density infiltrative mass, in this case involving the occipital horn of the left lateral ventricle. The T2 weighted sequences show that this lesion involves the splenium of the corpus callosum and also demonstrates some surrounding vasogenic appearing edema. Here are some contrast enhanced images. You can see there's heterogeneous enhancement with what looks like some central necrosis. So our imaging findings involves the splenium, low density on CT, central necrosis. All this is consistent with a high-grade glioma. Pathology was not a surprise. This turned out to be a glioblastoma multiforme. Here's a related case. It's a 62-year-old with altered mental status. And we can see a heterogeneous, irregular mass with vasogenic edema, in this case involving the frontal horn of the left lateral ventricle. Here's the T2, and you can see there's extensive vasogenic edema that extends all the way to the cortex. On the contrast-enhanced sequence, we can again see heterogeneity consistent with central necrosis. We can see involvement of the genu of the corpus callosum. But something a little different than our last case, we see a second enhancing lesion in the left frontal cortex. Should we be considering metastatic disease in this patient with multiple enhancing lesions? No, we need to realize that high-grade gliomas often have satellite lesions, particularly within the edema field surrounding the main lesion. And in this case, pathology showed that this was a glioblastoma multiforme. Case 4 is a patient who presented with acute nystagmus. And the first thing we see is a right cerebellar hematoma. But when we look a little closer, we'll see that there's edema surrounding the hematoma. So we start thinking about the possibility of hemorrhage into a pre-existing lesion. Here's the MR. The first lesion is a GRE, which demonstrates the hemorrhage. The second is a T2, which confirms the surrounding edema. And then I've got two contrast-enhanced T1s. So we were concerned about hemorrhage into a pre-existing lesion, And in a 52-year-old, the most common pathology for an intraaxial posterior fossa mass would be metastatic disease. We didn't see very much enhancement on the posterior fossa post-contrast image, but because we were concerned about metastatic disease, we were meticulous in looking at the rest of the brain, and we found multiple small enhancing lesions consistent with metastatic disease. And I'm showing you one here in the right parasylvian region. Well, our findings launched further imaging, including a body CT. And here you can see that the patient has a nasty-looking left renal mass, which at pathology turned out to be a renal cell carcinoma. When you encounter hemorrhagic brain mets, besides renal cell carcinoma, consider melanoma, thyroid, choriocarcinoma. These have a high propensity for showing hemorrhage when they metastasize. Lung and breast are so very common that even though on a percentage basis they don't show hemorrhage very often, you need to consider them in your differential diagnosis. Case 5. This was a patient who presented with vision problems. And even on the non-contrast CT, you can see a low-density lesion that's involving the sella and suprasellar cistern. And given the clinical presentation of vision problems, we're concerned that the chiasm was compressed. Visual field testing was performed and shows the classic bitemporal hemianopsia that confirms that the chiasm is being compressed from below. Here's the MR. I'm showing you post-contrast images. And you can see that this lesion is peripherally enhancing, and it has a sellar and a suprasellar extent, perhaps best seen on the magnified sagittal view. Here's a magnified coronal view, and I chose this image to show you the wasting of this lesion as it passes through the diaphragma celli. The diaphragma celli is a dural reflection that covers the sella. Now, this appearance to some people suggests a snowman. On the other hand, in Tucson, Arizona, we don't build very many snowmen, so I'll leave the snowman sign to you. At pathology, this lesion turned out to be a cystic macroadenoma. Not unexpected. I think it would have been reasonable to consider craniopharyngioma, but craniopharyngiomas are more common in a younger age group. Case 6. This was a 12-year-old who came to the ED complaining of headache. The docs did a really good job. On ophthalmologic examination, they diagnosed papilledema. Because of the patient's age, we went to MR to spare the patient the radiation of a CT. Here I'm showing you FLAIR and T2-weighted sequences, and the hydrocephalus is pretty obvious. If you look more carefully, you'll see T2 prolongation, particularly adjacent to the frontal horns, and this is evidence for transependymal flow. Now, papilledema is an ophthalmologic diagnosis, but it does have imaging correlates that I'd like to share with you. So I've magnified the T2-weighted axial sequence to focus on the patient's right eye. And the red arrow shows dilatation of the optic nerve sheath, whereas the green arrow shows bulging of the optic nerve head. This is a pretty florid example of papilledema secondary to increased intracranial pressure caused by the hydrocephalus. Sometimes all you'll see is flattening of the posterior globe. Now, of course, we wanted to know what was causing the hydrocephalus, so here are some images through the posterior fossa. The first is a diffusion-weighted sequence, which is positive, indicating a lesion of high cellularity. The second is a T2, which shows some heterogeneity within the lesion. And the third is a contrast-enhanced T1 that shows heterogeneous enhancement. At pathology, this lesion turned out to be a medulloblastoma. Case 7. This is a 50-year-old who came to the ED with altered mental status. The non-contrast CT shows me a patient who's in real trouble. The first thing you see is a low-density mass causing subfalcine herniation. And then my eye moves caudally to look at the brainstem, and we see that not only do we have loss of sulci, but we have loss of cisterns at the base of the brain. So this patient is in trouble. If you didn't find the axial images very convincing, have a look at this sagittal reformat. You can see that the increased intracranial pressure is causing a descending herniation, where the brainstem is being pushed downward through the tentorial incisura. And the imaging hallmarks that you want to look for are the cisterns around the brainstem. Notice that the prepontine cistern is gone, and the quadrigeminal plate cistern posteriorly is nearly completely gone. Notice that the fourth ventricle appears to be compressed, and if you look a little further caudally, you'll notice that the tonsils are starting to move into the foramen magnum, and we're on the point of a tonsillar herniation as well. Sometimes you need to move quickly in these sort of emergencies to save the patient, and I'm proud of the rapid response shown by our neurosurgical team. They did a wide craniectomy with the surgical goal of decompressing the brainstem. They weren't trying to resect the lesion, just decompress the brainstem. Here you can see brain herniating outward through the open craniectomy defect, but you can also see that the basilar cisterns have started to return to normal. We can now see a fourth ventricle, and the tonsils look like they're in a more normal position. Once again, the sagittal reformats are quite striking. On the left, I'm showing you the pre-op, and on the right, the post-op. Notice that following decompressive surgery, we now have a prepontine cistern. We can see the fourth ventricle much better, and we have cisterns around the base of the brain. The tonsils are now in normal position. This is just a diagrammatic representation of some of the different sorts of herniation that I've shown you in this case. We've seen descending herniation, subfalcine herniation. On the post-surgical view, a transcalvarial herniation through the craniectomy defect, and the tonsillar herniation best demonstrated on those sagittal reformatted images. Once the patient was stabilized, we performed an MR because we were interested in diagnosing that low-density mass that we had seen. Here on a contrast-enhanced image, you can see a regular peripherally enhancing solitary mass. This is consistent with a high-grade glioma, and at pathology, the lesion turned out to be a grade 3 astrocytoma. I don't think on imaging you really could have differentiated it from a glioblastoma. Now, the MR also showed us evidence of a right posterior cerebral artery infarct. You can see the high signal on the trace diffusion sequences and the low signal on the corresponding ADC images. So what happened here? We acted quickly to preserve the brainstem, and in fact, on these diffusion sequences, you can see that the brainstem is quite well preserved, but we suffered an infarct anyway. I think this little anatomy review will help us to understand what happened in this case. I'm showing you a normal basilar artery CTA. The red arrows point to the posterior cerebral arteries. The green arrows point to the superior cerebellar arteries. Something that's pretty tough to see on CT, the tentorium lies between the posterior cerebral artery and superior cerebellar artery. So, in a descending herniation where the brain is being pushed downward through the tentorial incisura, you can see how the posterior cerebral artery would be compressed. And in our case, the mass was right-sided, so there was greater compression on the right posterior cerebral artery, which unfortunately resulted in an infarction. Let's summarize what we've covered over the last 20-odd minutes. Brain tumors may present with either nonspecific symptoms or with localizing findings, and I've shown you some examples of each. Our job is to diagnose the brain tumor and at the same time beware of mimics. I've shown you a stroke mimic and a hemorrhage mimic. Your accurate diagnosis can help to guide further workup. I think that perhaps even more important, particularly in the acute setting, is to recognize the conditions requiring treatment, such as compression of vital structures. And I've shown you compression of the medulla, compression of the optic chiasm, and that case of compression of the posterior cerebral artery. Certainly, you want to report hydrocephalus because the patient may need to be emergently shunted, and you want to recognize the signs of increased intracranial pressure, particularly when they lead to herniation. Well, that concludes my presentation, and I thank you for your kind attention. Please stay safe, and with a bit of good luck, we'll be able to interact with each other in person next year in Chicago. Take care, and thanks.
Hello, I'm Orlando Ortiz, and I will be discussing spine tumor emergencies. Our learning objectives include a review of the clinical presentation of patients with acute spinal canal compromise, an understanding of the role of imaging and the evaluation of these patients. I will also reinforce the use of specific tools in the evaluation and management of patients with spine neoplasia, including the epidural spinal cord compression scale, the spinal instability neoplastic scale, and the NOMS decision framework. Metastases in myeloma account for a majority of spinal axis tumors. It's important to remember this when evaluating imaging studies on these patients with suspected spinal cord compression. That past medical history may come in handy in terms of trying to identify a specific type of tumor. A neoplasm may involve one or more of three spine compartments: intramedullary, intradural, extramedullary, or extradural. In this particular case on the right, we see an enhancing lesion within the cervical cord, an intramedullary metastasis. Additionally, we see metastases involving the spinal axis. Up to 20% of patients with disseminated cancer can experience spinal cord compression. There are approximately 20,000 new cases of spinal cord compression each year in the United States. Several factors may result in mass effect upon the spinal cord, whether due to neoplastic tissue, pathologic fracture with osseous fragments, alterations in alignment with vertebral collapse. In this patient with stage 4 thyroid cancer, we see that the rather large heterogeneously enhancing lesion is growing directly through the C5 vertebra and into the cervical epidural space where it is causing spinal cord compression. In this patient with a history of breast cancer, the spinal canal compromise is due to two pathologically compressed vertebra with retropulse bone fragments into the spinal canal, resulting in conus medullaris and chorda equina encroachment, impingement, and compromise. In this patient, an intradural extramedullary mass is associated with spinal cord compression. The lesion is calcified and actually turned out to be a thoracic meningioma. Patients with spinal cord compression will often present with back pain. The pain may be persistent or progressive, or it may be mechanical. Mechanical pain is pain that occurs in association with movement, change in position, or weight bearing. There may be radicular or girdle pain. The patients may experience motor weakness, sensory loss, or loss of sphincter control. The prognosis for neurologic outcome in these patients is based on several factors: pretreatment neurologic status, tumor biology, and tumor location within the spine. The pretreatment neurologic status correlates with any measure of post-treatment recovery. For example, if the patient is able to walk at the time of diagnosis, then they are likely to retain this function after treatment, as compared to a lower likelihood of that outcome if they were previously unable to walk at the time of their diagnosis. It is the behavior of the tumor, whether primary or metastatic, that determines the likelihood and rate of spinal cord compression. The bottom line here is that aggressive lesions grow fast and can quickly result in spinal canal compromise and spinal cord compression. If we look at cancer statistics in the United States from 2019, we see that prostate, breast cancer, and lung cancer are amongst the most common cancers, and these have a very high likelihood of involving the spinal axis when they metastasize. Tumor location within the vertebral column or spinal canal determines the clinical presentation, is a factor in the development of spinal cord compression, is a prognostic factor for spinal instability, and influences the approach for subsequent treatment or treatments. The imaging workup in patients with suspected spinal cord compression includes radiography. This study is often obtained as an initial test in the emergency department. It certainly provides a good overview of the axial skeleton. However, it has limited sensitivity, specificity, and accuracy for identifying neoplastic disease within the spinal axis. On radiography, we may see lytic or plastic bone lesions. Sometimes it can be subtle, as is in this case in the right, where there are subtle lesions throughout the entire spinal axis. This study could easily be read as normal. Additionally, we may see pathologic vertebral compression fractures and alignment abnormalities. Nuclear medicine studies such as skeletal scintigraphy and PET-CT, while helpful in the oncologic evaluation of these patients, are usually not appropriate as initial tests in the evaluation of suspected spinal cord compression. Computed tomography is excellent for assessing the osseous morphology, integrity, and alignment of the axial skeleton. In some cases, it may be appropriate for the evaluation of suspected spinal cord compression, especially when the patient cannot undergo MRI and may also require a CT myelogram. CT is useful for surgical and interventional planning and is very helpful in the assessment of extraspinal oncologic findings. This is the same patient as shown before on plain film with extensive lytic lesions throughout the spinal axis. They're more obvious on the CT sagittal reformations. Additionally, in this patient, the chest CT shows lung lesions, and the abdomen CT shows a right upper pole renal mass. MRI without and with intravenous contrast is the study of choice in the evaluation of suspected spinal cord compression. It really is the only study that consistently evaluates the epidural space and the spinal cord, as in this patient with lower thoracic canal compromise due to retropulsed vertebral body into the spinal canal. Image-guided biopsy is a diagnostic tool that can be utilized with fluoroscopic or CT guidance and helps to identify tumor histology, which is in itself useful in treatment planning. For example, in our patient with the thoracic and renal lesion, a biopsy of the iliac bone shows that this lesion is metastatic renal cell cancer. And so, in addition to being helpful for imaging guidance, CT can show lesion locations, especially when combined with PET, as in this case we see a lower cervical metastatic lesion in this patient with prostate cancer. We can see the lesion matrix, in this case blastic for this patient. We can identify if there is displacement of osseous fragments or if there's alignment abnormalities related to pathologic vertebral compression fractures on CT. And then CT itself can be useful for surgical planning and post-surgical evaluation, as in this case, the patient underwent surgical decompression and posterior spinal fixation for that cervical lesion. CT, however, is limited in the evaluation of the epidural space. MRI will show marrow replacement, and again we emphasize the value of the non-fat suppressed T1 weighted sequence as shown on these axial and sagittal images for identifying marrow replacement. We can see destruction, deformity, and collapse of a vertebral body on MRI, and we can see paraspinal soft tissue. The epidural space is elegantly evaluated, particularly on fluid-sensitive sequences and on contrast-enhanced sequences. We can see the subarachnoid space as well, and we utilize the T2 sequence or fluid-sensitive sequence to look at the subarachnoid space. And lastly, MRI is excellent for identifying lesions within the spinal cord, for identifying spinal cord displacement and deformity, and for looking at spinal cord edema. And so with spinal cord compression, we'd expect to see mass effect on the spinal cord. It's often helpful to compare the level of suspected spinal cord compression to our more normal appearing level. And so on the axial image on the right at the cervical spine level, we see clear CSF around a normal appearing cervical cord. And in the lower cervical spine, we see a deformed cord with this markedly infiltrated cervical vertebra. In the setting of metastatic disease or multiple myeloma, it's often helpful to obtain images of the entire spinal axis with either MR or multi-detector CT. This helps to localize levels in cases where there's a solitary lesion. It's also helpful in determining if there's more than one level of spinal cord compression or spinal instability. In this particular case, in our gentleman with prostate cancer, we see that there are two spine segments with spinal cord compression, the cervical spine and the thoracic spine, as shown on these contrast-enhanced sagittal, and axial images. We cannot underemphasize or overemphasize the value of prior studies in these patients. They allow us to assess for interval change, and they also allow us to estimate the rate of change. For example, in our patient with cervical spinal cord compression, we see that a study 4 months earlier was relatively normal except for degenerative changes. In terms of defining spinal cord compression, there are several terms that are used interchangeably: encroachment, impingement, compression. And it's important to get a feel and understanding for what these might mean. Encroachment being an advancement beyond the usual proper limits, and these are dictionary definitions. Impingement, having a mass effect, making an impression. And compression, the action or state of being squished down or squeezed, suggesting an element of volume reduction with respect to mass effect. And with these terms in mind, how can we assess the severity of spinal cord compression? Well, certainly we can use one scale that has been validated. This is the 6-point epidural spinal cord compression scale, with grade 0 being osseous disease only, and grade 3, the most severe, consisting of spinal cord compression with complete CSF effacement. This scale utilizes the T2-weighted sequence in order to assess the level of greatest compression. And so with grade 2 or 3 thoracic involvement, for example, the highest risk of developing rapidly progressive paralysis is observed. So there is some prognostic significance to this scale. Grade 2 or lower lesions have better neurological outcomes with minimally invasive spinal stabilization. So these findings make sense. So less disease in the epidural space associated with the spinal instability neoplastic scale is an assessment tool that has been developed to help evaluate patients with spinal neoplasia. It's also a prognostic tool and assist in surgical decision making. And so, with this scale, 6 variables are assessed and scored. One is clinical, and that is a characterization of pain, and the other 5 are imaging-related variables. These scores are added. Low scores, which indicate stability, range from 0 to 6. Intermediate scores ranging from 7 to 12 are indicative of indeterminate stability, and high scores of 13 to 18 indicate spinal instability. The indeterminate and instability categories are often used to facilitate a recommendation for surgical consultation. And so, with respect to location, junctional lesions get the highest score of 3, and these are at the cranial-cervical junction, cervical-thoracic junction, thoracolumbar junction, and lumbosacral junction. Mechanical pain, pain with motion movement, gets a score of 3. Lytic lesions get a score of 2. Spinal alignment gets a score of 4. Notice there are different numbers assigned to each of these findings, and you have to pay attention to these numbers. They're not necessarily consistent. Vertebral body collapse greater than 50% gets a score of 3. Posterolateral involvement also gets a maximum score of 3. Well, let's look at a case. In this gentleman with progressive low back pain and lower extremity weakness, an L3 lesion gets a score of 2. Pain 3. Lesion type lytic 2. Vertebral body collapse partial 2. Posterior element involvement 3. Total score 12. The axial images confirm the bilateral posterior element involvement. And this particular lesion is ranked as potentially unstable. And indeed, was 3 days later, when brushing his teeth, this patient experienced a pop in his back. Notice that L3 lesion now is worse. There's greater compression, there's malalignment. The patient was immediately taken to the ER because he developed a Corda-Quina syndrome. and underwent spinal decompression with posterior stabilization of the lumbar spine. And these sagittal and axial CT images demonstrate the marked decompression of his spinal canal at the L3 level. So the mainstays of treatment for spinal cord compression include surgical decompression and radiation therapy. With respect to surgical decompression, the goal is complete tumor resection. However, it's important to determine the tumor type prior to surgery, if at all possible, to help avoid overtreatment of benign disease and undertreatment of malignant disease. Our value as radiologists includes giving a full description of the anatomic extent of the lesion to help facilitate surgical and radiation treatment. It's important to note that radiation therapy may consist of either conventional external beam radiation therapy and or stereotactic radiosurgery. And again, tumor histology is very important because there are radio-resistant tumors and radiosensitive tumors. A study comparing direct decompressive surgery plus postoperative radiation therapy to radiation therapy alone showed superiority of the decompressive surgical approaches to restoring spinal stability and optimal neurologic outcome for these patients. Spinal cord decompression, therefore, can provide dramatic improvement in neurologic function. And again, the key determinants are the rate of neurologic compromise, the interval between paralysis to treatment, and certainly the type of approach that's used to decompress the spinal canal. Anterior approaches have a much better result in multiple series as compared to posterior approaches. The last algorithm I like to talk about is the GNOMES decision framework, which utilizes a multidisciplinary approach to evaluating and managing metastatic spine disease. And there are four important assessments. A neurologic assessment, which certainly relies on part on the epidural spinal cord compression scale. An oncologic assessment, which is based upon the tumor's expected response to available treatments and the duration of that response. Mechanical instability, which again utilizes the spinal instability neoplastic score, and systemic parameter, which includes extent of disease and medical comorbidities, the ability of the patient to essentially tolerate the proposed treatment, and how long they're expected to survive given their extent of disease and their tumor histology. Let's look at an example of how we might use this algorithm. This gentleman presented with 3 months of mechanical back pain, which did not respond to radiation therapy. The axial CT image of the chest with contrast and the MRI axial images show an epidural spinal cord compression scale of 2. If we look at his SIN score, it's 7. And what we ended up doing for this patient, who actually presented with metastatic disease and with back pain as his first diagnosis of metastatic lung cancer, what we did actually, we were able to get inside of that lesion percutaneously, ablate the lesion, and then put cement within that vertebral body and within the lesion and stabilize it, and he had complete and immediate pain relief. Another patient with 10 out of 10 crippling low back pain. She was bedridden from her metastatic lung cancer due to this metastasis to the lumbosacral junction. Her epidural spinal cord compression scale is 0, but her SIN score is 14. And so what we ended up doing for this patient with an alignment abnormality and with this pathologic involvement and fracture of at the lumbosacral, we looked at her GNOMES decision framework, and you can see she has a radio-resistant tumor, unstable by SINS, and low grade by epidural spinal cord compression scale. So she is ranked according to this decision matrix for treatment with stabilization followed by stereotactic radiation surgery. And so we ended up treating her percutaneously, biopsy the lesion to confirm the metastatic nature of the tumor, performed radiofrequency lesioning and sacroplasty to stabilize the sacral promontory and sacral. Her pain was immediately relieved. So that's how we use the Nome's decision framework in helping to treat these patients from a multidisciplinary perspective in the IR suite. In conclusion, we've reviewed the clinical presentation of patients with acute spinal canal compromise. We have a better understanding of the role of imaging in the evaluation of these patients, particularly MRI and CT. And we certainly can see how useful scales such as the epidural spinal cord compression scale, the spinal instability neoplastic scale, and the Nome's decision framework, how useful they can be in the evaluation of these patients. And we certainly should try to utilize these tools in our reports when describing and addressing these patients. And we should certainly be comfortable with the dialogue in the tumor boards. So when we discuss these patients, we can all communicate using the same language with these validated tools and approaches based on evidence-based medicine. Thank you very much.
Hi, I'm Alan Conquero, and I'm going to talk to you about head and neck tumor emergencies. So when we talk about head and neck cancer, we're basically talking about squamous cell carcinoma, which is by far the most common variety. It's classically associated with alcohol and tobacco use, but in recent decades, human papilloma virus-associated squamous cell carcinoma has become more and more common and now accounts for more than 70% of these tumors. Why do head and neck cancer patients come to the emergency room? Well, if their complaints are going to lead to a first diagnosis of head and neck cancer, then it tends to be because of dysphagia, stridor, neck mass, sore throat, odynophagia, otalgia. Patients who have already been diagnosed with head and neck cancer and are undergoing treatment or have previously can come for similar reasons, but also because of bleeding, fatigue, weakness, tube complications, and wound care, amongst other reasons. So, acute life-threatening emergencies in head and neck cancer patients, we're basically talking about two things: airway obstruction and arterial bleeding. Now, head and neck cancer CTs, and especially patients who've had prior treatment, they can be quite difficult. There's a number of post-treatment complications that we have to be aware of and recognize. There's a number of other considerations to take into account, such that is there evidence of recurrence or tumor growth? Does the patient have an acute infection? How do we accurately describe the altered anatomy? A lot of that is beyond the scope of this talk, but I'll just say that careful comparison with prior exams, if you're lucky enough to have them, careful review of the electronic medical record if you have access to that, including looking at what the ENT exam was, and really sort of trying to figure out what question do they want answered. That can help you to craft a helpful report. So let's take a look at the first case. A 62-year-old man with a smoking history comes to the ED. He'd had 6 months of sore throat and growing neck mass, but was acutely short of breath. So his CT, so far so good, but as we get down into the larynx, we see that he has a large mass, predominantly right-sided, but it's crossing over to the left side, going through the thyroid cartilage into the strap muscles. And then we see just how narrow the airway is here at the supraglottic level, only about 2 to 3 millimeters across. And this patient had squamous cell carcinoma, and he got an urgent tracheostomy. Another patient, 38-year-old man who had had a floor of mouth squamous cell, and then had glossectomy, neck dissection, tracheostomy, flap reconstruction, then several recurrences, but had recently been doing well, such that his tracheostomy was removed. He came to the ED 8 months after that with hemoptysis and shortness of breath. His CT, we see the evidence of the glossectomy and the flap reconstruction. And then we see this large mass in the right neck projecting into the pharynx. If we trace the airway here from the oral cavity, we see the passage here on the left side is really quite narrow, only about 2 to 3 millimeters. So another example of severe airway obstruction due to a tumor. This was also squamous cell carcinoma, and this patient also required an urgent tracheostomy. Our third patient, a 61-year-old man who had left true vocal cord squamous cell carcinoma, which was treated with radiation. He'd been keeping up with his ENT follow-up visits and had this persistent problem with laryngeal edema after radiation. He'd been given steroids with some success, came to the ED 2 weeks after his most recent ENT visit, complaining of progressively worsening stridor and shortness of breath. So his CT, there is some motion artifact here, but I think we can make out that the epiglottis is thickened, the aryepiglottic folds are also thickened. And so this diffusely thickened appearance is not uncommon in post-radiation patients. In his case, we're also seeing his vocal cords in a medial position bilaterally. And so this patient was in extreme distress. He was intubated emergently in the ED by anesthesia. It was a difficult intubation. His laryngoscopy revealed a thickened epiglottis and glottis with medialized vocal cords bilaterally, which we saw in the CT. Now, when you see that, I mean, that could be a transient finding just due to phonation or breath holding, but in his case, it was fixed. He had tracheostomy prior to discharge, and then on follow-up, persistent fixation of those vocal cords in the medial position with persistent edema. His ENT surgeon determined that he had posterior glottic stenosis, and he's been offered treatment for that, but is reluctant, and so he remains tracheostomy dependent 4 years later, despite being cancer-free. So, airway obstruction in head and neck cancer patients, that can happen as just direct mass effect due to the tumor, as we saw in the first 2 cases. Usually that situation is avoided because patients present sooner. They're diagnosed before their airway becomes so narrowed. And so as part of their evaluation and treatment, they get a tracheostomy to secure the airway before a crisis develops. But that doesn't always work out that way, as we saw in the first 2 cases. Other ways that tumor can cause airway obstruction, well, extensive nodal metastatic disease can cause extensive cervical lymphedema, which can compromise the airway. Aggressive thyroid tumors can involve the recurrent laryngeal nerves bilaterally and cause bilateral vocal cord paralysis, which can prevent abduction during inspiration and lead to respiratory distress. And then there are a number of treatment-related airway obstructions, including tube malfunctions. So these patients have tracheostomy tubes very commonly, and there are a number of complications that they can have that are not specific to head and neck cancer patients, like obstruction by secretions or granulation tissue or by hemorrhage. Patients who recently had surgery can have postoperative collections or hematomas that affect the airway. Post-radiation patients can have edema, which can be, if severe enough in the larynx, can cause obstruction of the airway, which our third patient had. And he also had posterior glottic stenosis, which is a form of scarring that keeps those vocal cords fixed in a medial position. And that's associated with radiation therapy, although it's also known to have infectious and inflammatory causes. So let's move on and take a look at this patient, a 65-year-old female who had multiple prior head and neck squamous cell carcinomas. She had a PET-positive lesion in the left pharynx and was admitted for trach secretions and low-grade fever, but in her first day in the hospital, she coughed and had a large hemorrhage. That prompted a CTA. And so we'll look at it here in the soft tissue windows first. We see her tracheostomy, this sort of diffusely edematous look to the neck, which is common in post-treatment patients. And then here in the left neck, there's this low attenuation area with some gas bubbles and a trail extending to the pharynx. And those gas bubbles are coming close to the distal left common carotid artery. Oh, what's that? Well, we'll take a closer look at that in a moment. But, it's important to look at the soft tissue windows to just see what's going on around the vessels. And then now we can look at the same images, but now windowed to look at the vessels. And we'll keep our eyes on that left common carotid artery. Here we're getting into that low attenuation material with the gas from the fistula to the pharynx. And we see the gas bubbles are coming close to the common carotid artery. And then here we have this large, irregular outpouching abutting the superior horn of the thyroid cartilage just below the carotid bifurcation. So 3D volume rendered images of the same exam show that large outpouching of the distal common carotid artery. We saw from the axial images that it was adjacent to that low density material with the gas bubbles, and so that this is compatible with a pseudoaneurysm. So this patient then was taken urgently to angiography, and here this fluoroscopic image again shows that pseudoaneurysm, but it appears larger than it did on the CTA. And then we see evidence of active contrast extravasation. This was treated with a covered stent. So that is carotid blowout. It's a complication of treatment for advanced head and neck cancer that results in rupture of the carotid artery or one of its branches. It's associated with a number of different things that can cause injury to the vessels, and that includes prior aggressive resection, prior radiation, exposure of the carotid artery, either to a pharyngocutaneous fistula or an infected wound, for example. And then also persistent carcinoma adjacent to the vessel is also known to be a risk factor. Basically, any of these things or some combination of them cause injury to the arterial wall, which leads to rupture. We investigate this with CTA, and then in addition to the arterial phase images, venous phase images are helpful to help you get a better understanding of what's going on around the vessel in the soft tissues. So carotid blowout is classified as threatened, where imaging or clinical exam identifies a risk factor for injury to the vessel that will result in a hemorrhage if nothing is done. Impending carotid blowout is when a patient has a transient hemorrhage that resolves spontaneously or with packing or pressure. That's known as a sentinel hemorrhage. And then acute carotid blowout is hemorrhage that does not resolve with packing or pressure. This is treated with endovascular treatments, which can include permanent carotid occlusion, covered stents, and branch embolization. When we're evaluating this, we want to look at both the perivascular soft tissues as well as the vessels. So in the perivascular soft tissues, the most important finding is an exposed vessel. Is a substantial portion of that vessel immediately surrounded by necrotic tissue or exposed to a pharyngocutaneous fistula. And then surrounding enhancing tumor or adjacent but not completely surrounding non-enhancing necrotic tissue also places the vessel as risk. So after we look at the surrounding soft tissues, then we want to look at the vessels themselves to look for evidence of vascular injury, which can be pseudoaneurysm, active contrast extravasation, vessel irregularity or stenosis or AV fistula. These are signs of vessel injury that are not specific to carotid blowout. They're just general findings of vessel injury, but in the context, are compatible with carotid blowout. So let's take a look at this case. 53-year-old woman, stage 4 supraglottic squamous cell carcinoma. She had sort of, long-standing low-level bleeding from the right neck, but came to the ED after a larger episode of hemorrhage. So her CTA, I'm showing you the venous face first in soft tissue windows so that we can see what's going on. Large mass in the right neck, necrotic. There's surrounding and there's enhancing soft tissue at the periphery of the mass. There's gas within the mask, probably due to a communication with the pharynx. And then within this necrotic portion, there is this contrast collection here, which we're going to get a better look at when we look at the arterial phase images from this exam. So now in the arterial phase, we're going to keep an eye on the right side. There's the carotid bifurcation. Here's the external carotid artery. Here is the mass. Oops, wrong way. And then we're going to get into this round contrast collection with a little tubular extension that makes it clear that we're dealing with a vascular structure. We can't quite trace it back to the adjacent facial artery here. And so now we'll look at volume rendered images from the same exam. There's the facial artery. Here's that contrast collection with the little adjacent tubular extension. So that's compatible with the pseudoaneurysm. The patient went to angiography. We did not see that contrast collection. Perhaps it had been occluded when the patient had the wound packed, but there was tumor blush. And the interventionalist embolized some external carotid artery branches with reduced tumor blush afterwards. All right, next case, a 72-year-old man who had a history of mucoepidermoid carcinoma, a salivary gland tumor, and he came to the ED with a large episode of spitting up blood. So his CTA, again, we're going to see the collection of gas and fluid with a communication to the pharynx, so that's compatible with a fistula. And then this material with the gas and fluid is extending close to the external carotid artery here. We see it in very close proximity. So now we'll take a look at these same images, but windowed to examine the vessels. And so we'll keep an eye on the left side. And so here, as we get to the carotid bifurcation, the external carotid artery is starting to look a bit irregular. It gets a little dilated. There's a medial outpouching as well as a lateral branch we're seeing here. And then it narrows, dilates again, and then there's an outpouching here. So when you're looking at these CTA images, it can be helpful to use MIPS or 3D volume rendered images to sort of try to get a handle of what's going on. Here on the MIPS, we just see that external carotid artery segment just looks abnormal. It has that pseudoaneurysm at the top, that also medial outpouching over here. We'll look at the 3D volume rendered images. And so again, just an abnormal segment of the external carotid artery with pseudoaneurysm here at the top. So this patient also went to angiography. It actually looked worse. That more proximal outpouching looks larger. This was successfully occluded. So our last case, a 62-year-old woman, had a history of squamous cell treated with radiation. Then she had a second primary squamous cell of the left tonsil. She had that treated with a left tonsillectomy, partial pharyngectomy, left neck dissection, and radial free flap reconstruction. She had some minor bleeding from the wound, which brought her to the ED. She got a CTA, lots of post-surgical change here. All right, we're in the carotid bifurcation on the left side. There's the external carotid artery. That's anastomosed to the radial artery here as part of this flap reconstruction. But as we look at the internal carotid artery, we see that there is this outpouching here on the lateral aspect. So MIP images show that lateral outpouching. Volume rendered images show the same thing. And so this patient, she had the CTA done at 5 a.m. And then, honestly, when I spoke to the ED attending, he wasn't that impressed with the initial hemorrhage that had brought her to the ED, but then she had a subsequent minor bleeding episode in the ED. And after they were informed of the findings on the CTA, she was scheduled to go to angiography, but had a large hemorrhage from the neck while waiting for angiography. So she was rushed to the OR, was packed, and then transferred to the IR suite, where that outpouching compatible with pseudoaneurysm of the ICA was noted, again looking larger than it did on the CTA, and this was successfully occluded. So in summary, we talked about airway obstruction and arterial bleeding as being the major life-threatening complications in head and neck cancer. And just to focus on the carotid blowout, when a head and neck cancer patient presents with a hemorrhage, this is an emergency that has to be addressed right away. We typically evaluate this initially with CTA. As we mentioned, venous phase images are beneficial to get a better handle at what's going on in the soft tissues, because we know that exposure of the vessel to necrotic material or pharyngocutaneous fistula increases the risk for damage to that vessel. 3D images can be helpful for visualizing the pathology. And as we said, we should evaluate both the vessels and the perivascular soft tissues. Well, thank you for your attention.